Okay, so we just have to wait. There's two more people to come in.
Good morning, Doktor.
Alright, Assalamualaikum.
Waalaikumsalam.
Dua orang lagi. Satu, dua, tiga, empat, lima, enam, tujuh. Two more people. Siapa yang tak ada ni? Yang tak ada siapa? Zurain ya? Ke Zuzu tu Zurain lah? Ke orang lain?
Yeah. All of us are here, Doktor.
Okay, so we're going to start with Kitab Al-Fatihah. Okay. So I give it to you the two cases for the case-based discussion, or we call it problem-based learning lah. So PBL. And when you see the case, you know what is the problem. So the first one is the red colored urine. The second one is the delayed gross motor. So those are the problem that you will come across anyway. So from there you need to do further reading. Maknanya kalau ada red colored urine, then you just need to read what is the condition or pathology that can cause red colored urine and so on. So those are the way that you learn from problem-based learning. So far we still kuliah of medicine under Prof Mazuki still don't know in terms of how we're going to assess you. So previously when you were in year 3, you were given logbook untuk buat case presentation, long cases, procedure skill and so on. So at the moment we still don't know how we're going to assess you. So the only way that we can do now is we just doing the PBL style learning, and then what we'll do is so one of you will take turn to lead the case, and then we'll probably give him marks based on the way that you lead the case. Itulah the only way that we can do at the moment. So is this your first session for this week? Ke kau dah ada session lain lah?
Yes.
First session.
First session.
So obviously different mentor, different lecturers akan buat different style lah. But for the time being, I think I'm just going to do PBL style for, at the moment, until mana bila kuliah of medicine give us a green light for you to call patients, and then I'll give you the list of patients that agreed to be called for clocking. But for the time being, Prof Mazuki says they were having problem in terms of trying to sort out medical legal in terms of students contacting parents to clock in patient. So at the moment we are stuck here. because I've already got a list of questions that you can call, and parents already agreed to be called. It's just that Prof Marzuki says not yet at the moment, so we don't know when you guys can contact parents directly lah. So okay, so Nadia nak present, nak lead case ke apa? Kau orang lain lead case?
Someone else already been.
Okay, so it's been assigned to somebody else lah. Okay.
Yeah.
So pesanan penaja, keep your social distancing. Keep safe, stay at home as much as possible, and then I'll leave it to whoever presenting the first case to lead the case. Okay.
I'm going presenting I'm going to lead the first case. So can I have someone to summarize the info given for the first case?
I'll summarize it. For case 1, 6 years old, girl presented to emergency with red urine and with no dysuria, no frequency, and no abdominal pain, no history of trauma. She recently had her whole family had history of colds. However, there's no nose bleeding, no bruising, and also there's no joint problems. She has history of urinary tract infection at 4 years old. However, she was discharged due to normal ultrasound and not on any medication. She has no family history of renal problem, and her grandmother have hypertension.
Okay, thank you, Nadia. So basically, the chief complaint for this case is 6-year-old girl presented with hematuria. So first, I would like to ask, what is the possible causes of hematuria in this case? So anyone else to give possible causes?
Okay, so causes of hematuria, we can divide it into non-glomerular and also glomerular causes. And for non-glomerular, it can be due to infection such as bacterial infection or viral infection. It can also be due to trauma to the genitalia, urinary tract, or also the kidneys itself. And then it can also be due to stones. However, it is quite unusual in children. It can also be due to tumor, such as Wilms tumor, which is a nephroblastoma, and other bleeding disorders. For glomerular causes, it can be due to acute glomerular nephritis and also chronic glomerular nephritis, which usually comes with proteinuria. And other than that, it can also be due to immunoglobulin A nephropathy and familial nephritis such as Alport syndrome, and also
Okay, thank you, Rahid. So we have already had the list for the possible causes of hematuria in this case. So from this list, can we exactly narrow down the most likely causes? In this 6-year-old girl presented with hematuria, but no other symptoms like dysuria, frequency abdominal pain. So can someone like points for, points against for the possible causes?
So let's try to go into what question you want to ask parents regarding this presenting complaint. So basically, you got the scenario. So you got the list of possible differential diagnosis. So how are you going to extract more information from parents? Ataupun if you want to ask further questions to parents, try to narrow down what will be the possible working diagnosis. And so with this scenario, you got some idea, you got some informations, but you still want to have more information regarding this case. And so what is the list of questions that you want to ask parents?
So maybe for me, I would like to ask more about nephritic syndrome, which is, for example, if the patient have proteinuria or any facial edema. or edema, or sign or symptom of hypertension, such
Okay.
as headaches, lethargy.
Okay. So basically, if you're talking about nephritis, so you want to ask a question about frothy urine. You want to ask question whether is there any ankle swelling or facial puffiness. Okay, so try not to use words oedema to parents, because parents might not know the words oedema. So oedema is we are the one that who say this is oedema. So when it comes to facial, you ask about facial puffiness. When it comes to ankles, you ask about ankle swelling. Okay, and then you want to know in terms of history of possible hypertension, I think symptom of hypertension. And so sometimes hypertension is asymptomatic in children. So those are a bit difficult to extract from children and from parents. But if you ask parents, is the child looks, has the child ever complained of any headache? So 6 years old should be able to complain about headache if they got headaches. You also want to know, sometimes with the hypertension, they can have nausea, or sometimes they can have vomiting as well. So you want to know whether is there any history of nausea, or have the child complain of nausea or vomiting for the past couple of days or for the past week. Okay. And any other questions? So you're talking about that's nephritic syndrome question. So any other question you want to ask based on your differential diagnosis?
I think we can ask about the joint pain or any rashes to exclude any henox purpura.
Okay. So you want to know about, so basically you asked about rashes. So there's no, so in this case, it already says that there's no abnormal bruising, so which is a good thing. And then you want to know about joint problem as well. And then this case also says there's no joint problem. So the scenario kind of like ruling out henox purpura by itself. Okay, so what is henox purpura? We know that henox purpura is a clinical diagnosis, and you see the patient, you see the rash, you see the joint problem, and then you kind of like, it looks like this is henox purpura, given that you rule out urine problems. But by definition, what is henox purpura?
I think it's a type of vasculitis, which a combination of symptoms such as rash, abdominal pain, arthralgia, and also glomerulonephritis.
Joint pain,
Mm-hmm.
which is arthralgia, and then you got the skin lesion or skin purpura, and also nephritis, which is possibly possible blood in the urine, or sometimes protein in the urine as well. Okay, so if I ask you for the question, what is the 5 organs involved in henox purpura? Need to go back to Nurul Shahira. She's the one who leading the case.
I think 5 organ. So kind of
Okay, it's okay. If you don't know the answer, that's fine. You can always pass the question to your colleague. You can pick any colleague you want. You are the one in charge. You can pick your colleague to answer the question.
So I think the system that HSP henox purpura has, first is the dermatological, in which they will have purpuric rash. Second is the joint.
So before that, it's only 8 of you, and there should be one more student.
Only 8.
Only eight.
Only 8.
Yes.
Oh, I see. Sorry. That's one. Okay, fine. So okay. Carry on, Abby.
First is skin, because they have purpuric rash. Second is joint, because they have arthralgia, and the third one is abdominal pain. Fourth one is the kidney, in which they have glomerulonephritis. And the last one is periarticular edema. they have
Sorry, so
joint.
you got dermatology, which is the skin. You
Yes.
got joints. You got the kidney. Satu, dua, tiga. Lagi. So kidney, joint, skin. Dua lagi. Tak ingat kan? Abdomen, okay. Abdomen, okay. 4, 5. The fifth one. If you start, Abe, you can pass to your colleague. Your colleague might know the last one. I can see Zuzu was smiling, so she probably know the last organ involved. So Zuzu is Zurain kan? Kau orang lain. And anyone can name the last organ involved?
The lung.
Lung.
The lung or CNS.
Okay, so CNS. So that is the 5th organ involved. Okay, CNS. So your brain is the last organ involved. Okay, okay. Now back to Shaira. So how HSP lead to skin purpura? What is the pathogenesis? What is the pathogenesis that cause skin purpura in HSP? Okay, don't panic, don't panic. You can always pass the button to your colleague.
Anyone know?
No, you need to pick names. Anyone know? Anyone memang dah kesenyap. Anyone need to pick the name.
Maybe Haziq can.
Okay. Aziz is smiling, so he knows the answer.
So doctor, basically from what I understand, macam mana nak kata, HSP can cause the rash on the skin due to the IgA mediated IgA mediated reaction on the small vessel on the skin.
Okay, and then what happened? So when you got the IgA mechanism deposition on the small vessels, so what happened to the vessels?
The vessel. That one I'm not remember.
It's okay. You can pass the button to your colleague. I'm sure that your other colleague probably know the answer as well. Let's see who's smiling. One is that is smiling ni. So I think she know the answer. Zuzu want to say something. Let her answer the question. Alright. Masalah lagi lah mic Zuzu daripada dulu ni.
IgA deposition lead to inflammatory response.
Okay. What happened after that?
Complementary reaction.
Okay, so you got the complementary reaction, you got IgA deposition. So what happened after that? So you got the inflammatory reaction. After the inflammatory reaction, what happened to the vessels? What happened to what we call inflamed vessels?
Vasculitis.
Vasculitis, isn't it? So vasculitis means that you got the inflamed vessels. So the vessels become leaky, and the leaky, or we call it the permeability of the vessels become more. We call it more porous. So when you become more porous, so that's why you got the leaking of the red cells from the vessels to the surface of the skin, or underneath the skin. So that's why you got the purpura appearance of the skin because of the vasculitis. So you got the inflammatory reaction mechanism, IgA ke CTC4 complex reaction lead to the vasculitis. Vasculitis make your vessels become more porous, become more leaky. So that's why you got this deposition of the red cells underneath the skin that give the purpura appearance on the skin. So those are the pathogenesis of HSP on the skin. Okay, you got four other organs to explain to me. So then why HSP got joint problems, joint pain? Okay, I pass the button to apa Syairah. Syairah can pass the button to anyone else yang she prefer. Tak kisah siapa-siapa kan. Nadia boleh. Nadia pun dah ready nak jawab lah.
Anyone can answer?
anyone is not good enough. You need to pick the name.
For joint,
Okay, for join.
I think it's still the same due to IgA mediated that activate the inflammation and also the complement system, causing the deposition of the inflammatory cells at the joint space, causing the inflammation of the articular surface, causing the joint pain.
Okay.
That's
So it's kind of like, you know, halfly explained by Nadia. So basically you got all these inflammatory factors, inflammatory processes happen in the intra articular space that lead to inflammation around the joint. Yeah. So the thing that you need to remember as well, when you got the inflammatory processes happen at any joint or any organ, it will lead to production of more fluids to be accumulated in the space as well. So that's why sometimes with the HSP, you can see the joint is actually swollen because of extra fluids. So the inflammatory processes, inflammatory mechanism produce more fluids in that joint. So that's why it become more swollen with some more joint. So sometimes that process cause excessive fluids accumulation in that particular joint organ. So that's why you got pain in the joint, and sometimes you got swollen joint as well. Okay, so that's for joint. And then the kidney. Okay, the kidney.
I think for the kidney, when there's inflammation, there will be a disruption in the basement membrane integrity. So that's why patient may have presented with hematuria.
Okay, so it's the same thing as well. So whatever the mechanism of inflammatory processes happen, it lead to the vasculitis. Vasculitis make your vessels become more porous, become more leaky. So you lose some HSP lose protein as well, but mainly it's the hematuria that normally see in HSP. So that's why you got those kind of presentation for HSP. Now, so you got three there. So joints, skin, and also the kidneys. Now, who's going to explain about GIA involvement in HSP? Amirul dia dah macam apa? Very eager to answer the question.
So for GI, I think it's about the same because of IgA deposition. So when the IgA deposition cause immune complex reaction, cause inflammations, and cause vasculitis at the GI tract punya vessel. So cause when ada inflammation, ada leakage, ada extravasation, can sometimes cause abdominal pain and also bleeding, such as hematomesis and also melena.
Okay, great. You want to continue with CNS?
For CNS, I'm not sure.
If you can explain that for your GI, you should be able to explain that for CNS as well. So it's the same thing as well. It's the vasculitis processes, and so vasculitis processes you just imagine that the vessels are leaky in the brain. So the vessels are leaky in the brain. So you got deposition, either deposition of inflammatory process, inflammatory cascade and complement, or you can also say that it could be that there is leaking of the protein and also the fluids in the brain. When you got more fluids in the brain, your brain basically become more intense. Mana dia macam become more swollen as well. When it becomes more swollen, then sometimes it can increase ICP. So sometimes a patient with HSP can come with nausea, vomiting, or sometimes seizure as well. However, CNS involvement in HSP is very, very rare. So I've not seen anybody with HSP in my career so far coming with HSP CNS vasculitis. So I've not seen one yet. I've seen one CNS vasculitis, but it's not because of HSP, it's because of something else. But HSP vasculitis that involves CNS is rare, so I've not seen one so far. But those are the pathomechanism or the pathogenesis that get involved in those 5 organs for HSP. So that's finished for HSP in terms of your differential diagnosis.
Doctor, I have a question. Does children with HSP usually presented with fever as well?
So HSP is not fever. It's not really infectious kind of condition. It is more autoimmune conditions and that cause HSP. So you rarely has a patient with HSP come with fever, unless they got what we call it comorbid or co-infection with HSP. So sometimes you can say to parents that because it is autoimmune condition, so sometimes the patient can have a bit of URTI symptoms or infection a couple of weeks before the first presentation, like hematuria or skin purpura, but they rarely or normally don't really come acutely with the fever. So they normally come a couple of weeks after the illness. Okay. All right. So we cover a bit more about apa tadi? Tadi HSP. Before that, we cover about nephritis. So yes.
I have one question regarding HSP. These 5 organs, does it always come together, or they can localize one?
So normally it doesn't come together. So it can come bit by bit, but mainly that you guys normally see is the skin involvement and also kidney involvement. And sometimes you can have a patient with a joint problem, joint pain, and sometimes with a GI bleeding or abdominal pain as well. But as I said, you rarely see HSP that got CNS involvement. I've not seen one so far, but the 4 one, the skin, the joint, the kidney, the GI tract, those are the commonest organs that are going to be involved. The more common is the kidney and also the skin. Those are the 2 most common, and then followed by the joint, followed by the GI tract. But you normally say to parents that normally with HSP, you worry about those 5 organs, especially the kidney. Those are the first one that the top one that you worry, and then you say to the parents that HSP is mainly self-limiting. So about more than half of them will recover within a couple of weeks. Some of them will take some time to recover. And then you say about the complication of CNS involvement as well. But those are very, very rare to get involved. So those are the way that you say to them. So the 5 organs can happen at any time, but mainly is the kidney that is the most affected. Okay, so what other question you want to ask? So you got your nephritis, you got your HSP as part of your differential diagnosis. Any other question that you want to ask parents based on your differential diagnosis? So you can go back to your first the early discussion regarding what will be your list of differential. And then from there you know what question you want to ask. Okay, Syarah.
Any question anyone want to add?
So
Maybe
at
any
first, tak apa.
Okay, let's leave it. Siapa yang cakap ni? Awesome.
Wani.
Okay, bagilah bagi ke Wani lah. Tadi dia cakap.
Because at the first place, we suspect the patient may have post-rep glomerulitis. So we need to ask any recent infection to the kids, and also any symptoms like sore throat, runny nose.
Okay. So basically, in the case, it says that the child and also the family has a recent history of colon. Colon is if you lah, cold ni basically apa or masalah saya kata cold ni just a simple runny nose, bit of cough, a bit of sore throat. That's cold. Cold is not as severe as flu. Flu is more severe. Flu ni maknanya dia ada cold plus they might have myalgia plus prolonged fevers. Okay, cold can have fever, might not have fever as well. So cold can be might have a mild fever or no fever at all. So that's cold. Flu is more severe in terms of myalgia, high fever, prolonged fever. Sometimes you got arthritis as well with flu. So those are the difference between cold and flu. But cold can be from the streptococcal infection as well, because you can have a spectrum of degree of severity in streptococcal infection. You can have very severe tonsillitis or pharyngitis, or you might have a very mild bit of sore throat in streptococcal infection. So sometimes children who might have streptococcal infection don't really know that they got strep infection because it's so mild. So in this case, it says that recent cold. So it could be for the past 1 week or 2 weeks ago that this patient has, including the family as well. So reading this case, you'll be thinking about streptococcal glomerulitis almost immediately again when you see the case. But for us to have educational discussion, that's why we need to have further questioning, because even kalau korang clocking patient masa final pro pun, you know what is going on with this child, with the case. But as a part of final pro, you need to ask all question possibles to rule out other pathology, because that's how we assess your skill of taking histories, skill of eliminating other possible causes and so on. So that's why you still need to ask question. You still need to ask other question about HSP, other nephritis syndrome, or other pathogenesis. However, what is the common pathology in a child with hematuria? What is the question you want to ask? If you're thinking about the commonest thing that happen in a child. Okay, so I think Rahil want to talk about something. So let she talk first, and then she can ask question after that.
Actually, I would like to ask about infection, because she said that she has a history of urinary tract infection at the age of 4 years old. Then maybe it can become a recurrent UTI.
Okay, so infection is the most commonest thing that you want to rule out first, kan? So in this case, do we know whether she has fever or not? So in this case, we don't know whether she has fever or not, but it didn't mention that. So that's why UTI is still top of your list, because UTI is the most commonest presentation for hematuria. The most commonest you can have hematuria in UTI, isn't it? So that's why you need to ask about history of UTI. So you want to know about fever. So does the child has fever or not? So those are the questions you want to ask. Any other question you want to ask about UTI?
of dysuria, abdominal
Okay.
pain, or
So,
increase in urinary frequency
hmm.
and urgency.
Yeah, so you ask all those questions about dysuria, frequency, urgency, abdominal pain, and so on. And so those are the questions you want to ask as well. So frequency is basically the numbers of going to the toilet to wee or to pass urine, and frequency normally associated with we'll call it apa tu? Not emptying the bladder, apa namanya? What is it called?
Retention?
Incomplete voiding.
Yes, incomplete voiding. Thank you very much. Yeah. Dah lama tak cakap English, jadi dia macam slow sikit. So incomplete voiding. So the problem with in the child is they don't really know what is incomplete voiding. So normally what you can see is the child going to the toilet very frequently. So those are the feeling of incomplete voiding. Urgency, what is urgency? Urgency is basically unable to go to the toilet in time. So she feel the urge to pass urine. Normally she can hold the urine until she reach the toilet, but in a state of UTI, they might not be able to hold the urine longer. She'll probably wet herself before she's reaching the toilet. So those are the urgency kind of question you want to ask. Any other question you want to ask about UTI? What is other symptoms that can be associated with UTI? Azik lah, Azik pun lama dah senyap ambil. Azik tengah makan Azik. Share sikit sebut raya tu. Okay, so what are the symptoms that can be associated with UTI? That's not in that's not written in the case. Hello? Tak dengar apa? So what are the symptoms that can be associated with UTI? So we're talking about both dysuria, urgency, frequency, abdominal pain. We're talking about fever. What are the questions that normally associated with UTI?
I'm not sure. Maybe discharge?
Okay, you're talking about PV discharge, or sometimes you can ask about penile discharge as well. If there's a boy, it's a boy. So you want to know, is there any discharge down below? Okay, for girls, PV discharge is very important because sometimes you can have bacterial apa tu namanya, bacterial vaginosis kan, or sometimes you can have a bit of colonization in down below. That has, we call it, ascending tract of bacterial spreading. So sometimes you can ask about discharge. You can also have fungal discharge as well. So sometimes you ask parents, any discharge, what color is the discharge? Is it green, white, yellowish color? And sometimes what is the smell of the discharge? Sometimes fishy smell, very suggestive of fungal infection in a child. Okay, so you're talking about discharge. So what is two other questions you want to ask parents about UTI? Slow lah korang ni, slow ni. It's a bit slow ni. Lama sangat duduk rumah 3 bulan ni.
We ask about irritability, doctor.
Okay. So yes, you can have anybody with infection can come with irritability. Okay, but obviously in 6 years old, normally you don't really see a child of 6 years old coming with irritability, like rarely. Normally irritability is tend to be children less than 2 years old, where they can't really vocalize their problems, so they normally come with crying without any reasons, listless and so on. So those are the irritability that you can ask parents. So you can ask parents macam mana behavior dia, macam mana dia merengek ke ataupun menangis menangis tak ada sebab ke, and so on. Those are the questions you want to ask parents. Okay, any other question? Just focus on the UTI.
Foul smelling urine.
Okay, yeah, foul smelling urine. Okay, quite common as well. So normally you ask parents, ada tak bau macam apa, bau kuat ataupun bau busuk kencing dia compare daripada biasa. So those are the questions you want to ask as well. And last question. What is the last question that you want to ask?
Is there any flank pain?
Okay, so flank pain is towards pyelonephritis. So if you got you can have flank pain for pyelonephritis, and if it's just a cystitis, then normally just a lower abdominal pain. And sometimes if you got both cystitis and also pyelonephritis, you can have pain constantly in the flank and also in the suprapubic area. So those are the difference between cystitis compared to kidney stone is kidney stones tend to travel. The pain tend to travel from loin to groin. So that's what we know. Classic renal stones. For pyelocystitis, pyelonephrocystitis is a constant pain in the flank and constant pain in the suprapubic areas. So those are the difference between calculi and infection. Okay, that's the last one that I want to. I still want you to dig it out. The last question you want to ask is the symptoms that normally associated with UTI.
Cloudy urine, doctor?
Cloudy urine tend to be protein rather than sometimes you can ask about cloudy urine as well, because sometimes you can have this debris. So if you got infection in the cystitis, you got the debris in apa dia macam apa ada kita panggil apa sel mati that deposited in the bladder. Sometimes you can have cloudy urine as well, but cloudy urine is quite difficult to say lah, because cloudy urine can be what you eat as well. So kalau korang selalu makan patin tempoyak, misalnya, you can have a bit of cloudy urine as well. So especially if you eat a lot of durian, sometimes durian also can cause cloudy urine, because you got lot more protein in durian compared to other food. Kan Aziz kan makan banyak musangking kan. So cloudy urine can be as well, but it's not really something that is very suggestive of UTI in children. Okay. But what is other symptoms that normally associated with UTI?
Vomiting.
Yes, nausea and vomiting. So nausea and vomiting is almost almost pathognomonic, kind of strong association between UTI with nausea and vomiting. I'm not so sure how to explain that, but they were saying that there is a possible urea increment when you got UTI, or bit of toxic accumulation in the body that lead to nausea and vomiting. But yes, nausea and vomiting is question that you really want to ask parents if they has. If you're suspecting UTI. Okay, so you're talking about UTI, you're talking about nephritis, you're talking about HSP. Anything else? Yes?
Can bedwetting can be a symptom of UTI also?
Yeah, bedwetting also can be. Okay. So the next thing I want to ask is bedwetting or enuresis. Okay, bedwetting also can be a symptom of UTI as well. If you remember, bedwetting korang belajar masa year 3 kan? Can't remember. Is it year 3? Year 5? Bedwetting is year 3, I think. Is it year 3? I can't remember. Okay. So there's two type of bedwetting or enuresis. Okay, enuresis, especially nocturnal enuresis. So you got a primary nocturnal enuresis, and also you got secondary nocturnal enuresis. A 6-year-old girl, you expect she should be able to be dry by day and by night. 6 years old. 6 years old, you expect that you expect in terms of social developmental milestone, 6 years old should be able to be dry by day and by night. Okay. If a child has never been dry at night up to 6 years old, what we call that?
Primary enuresis.
So it's primary enuresis, okay? And then what is the difference between primary and secondary enuresis?
For the secondary enuresis, they have a period of dryness.
Okay, for how long? A period of dryness. 1 hour, 2 hours, 1 day, 2 days?
Not sure.
Rahil tahu kan? How long the period of dryness? Okay, the period of dryness for secondary enuresis should be at least 6 months. Okay, so before you say a child primary or secondary, you want to know has the child ever been dry for a period of time. So if mom says, oh, she's been dry for 3 months, and then she then wet again, so she's still a primary enuresis. A secondary enuresis is you need to be dry at least for 6 months, and then you wet again. So and then you become secondary enuresis. So those are the difference between primary and secondary. Okay, so the first thing you want to investigate for nocturnal enuresis or enuresis is you want to make sure that the child has not got any symptom of UTI. So what you do first is you send for urine microscopy or urine plus urine culture and sensitivities. Okay, if it's negative, then it's not UTI that caused the enuresis. And obviously the secondary enuresis, there's plenty more investigation you would like to do. You probably want to further investigate in terms of the bladder capacities. You want to investigate in terms of sphincter reflex. You might want to do the MRI spine to make sure the spine is normal. Because sometimes you can have very vague looking myelomeningocele or spina bifida that be missed. You probably want to see is there any other malformation of the pelvis that caused the enuresis. For the primary enuresis, you don't really do much investigations. You try to manage them by 4 years old with some medication. Before that, you try with the enuresis alarm and so on. As part of your management, we don't really do much in terms of investigation apart from sending for urine for to rule out UTI. But when you become the secondary, you probably need to think about endocrine, like diabetes mellitus and so on. So those are the things that you need to think about secondary enuresis. Also, you also need to think about possible sexual abuse in secondary aneurysm as well. Secondary enuresis, because sometimes a child might be abused by somebody, then psychologically become traumatized. So that's why they have a secondary aneurysm. Enuresis. Okay. If you heard any story about sodomites in tahfiz school, pondok and so on, sometimes if you read the stories, all these children that have been sent to tahfiz schools, aged 11, 12, 13, still having enuresis. But I'm sure that there are secondary enuresis, not really primary enuresis. If you read a story from, I don't know whether you know this guy, Syed Azmi Al-Habshi. one of them, he is one of the advocates, tried to bring all the perpetrators that caused case liwat, case sodomites in Malaysia. So one of the reasons why this child actually enuresis is not because they want to wet themselves. They wet themselves, mana at night before going to sleep, they basically purposely wetting themselves, mana kencing on the bed, so that they become smelly. Once they become smelly, those people don't come to them because they are smelly. So it's a protective mechanism for them to wet themselves, to wee at night, so that they're not being tidak diratah di waktu malam oleh orang-orang yang tertentu lah. So those are the so if you think about secondary aneurysm, you need to think about sexual abuse. Okay, so almost 11 o'clock. We need to move quickly. So you're talking about, sorry.
I have a question. For secondary aneurysms, how many times they need to bed on the wet for us to think of pathology? They have been dry for 6 months, and then is it only one bedwetting? We already.
So I'll probably give some time lah. Mana 6 months bedwetting dry, and then one bedwetting. You don't really say definitely this is secondary aneurysm already. You probably give some time. Probably give them about 1 month after that. If the child still wetting like once every week for 1 month, then I think you need to think about something else. So you need to think about pathologies. You probably want to do, as I said, you probably want to send for urine cultures, get the scan of the abdomen, kidney there. Probably you want to assess dia punya micturition in terms of capacity, holding capacity of the bladders. If there is any sign of neurological signs, you probably want to do a scan of the spine and so on. So it depends on your physical finding as well. And sometimes if you do everything come back normal, and then you probably just refer to psychologists or psychiatrists to see is there anything else that that mentally disturb the child that made them end up with secondary aneurysm. Okay, so you're talking about UTI, talking about HSP, talking about nephritis, you're talking about apa lagi? Aneurysm, yes, okay. And then what else you want to ask? So previously you mentioned about Williams tumor or nephroblastoma at 6 years old. Is it quite common to have nephroblastoma in 6 years old? Back to Syahirahan.
I don't think it's common in this kind of
So what age do you expect Williams tumor?
Two to 5 years old.
Okay, so I would say younger than that. So probably normally, yeah, the peak incidence of Williams tumor is about 3 to 4 years old. Okay, and the main thing about Williams tumor is the painless hematuria. So this child has been having multiple hematuria daily, but never complain of any pain. And when you feel the abdomen, there is a mass in the abdomen. So if there is mass in the abdomen with painless hematuria, then you should be thinking. And then the group age there between 3 to 5 or less than 6 years old, you should be thinking about Williams tumor. I'm not saying that 6 years old don't get Williams tumor. It is still possible. Even up to 7 to 8, it's still possible to have Williams tumor. It's just that it's not that common in that group. It's more common less than 5 years old. Okay, but obviously, if you got a child with painless hematuria, and then with the abdominal distension or abdominal mass, then you need to think about Williams tumor. Okay, what is the most commonest comorbid that is associated with UTI? Apakah satu penyakit ataupun satu condition yang quite common being associated dengan UTI? Panggil Zu. What is the most commonest comorbid that is associated with UTI?
Stones?
Okay, stone. Okay, stone. I would always say common in children. Stone is not common. Adult is more common. So if you ask about adult, kalau adult, what is the most commonest bacteria that cause stones?
Yeah.
Ada lagi ayam kokok waktu ni sebelah ni.
Ada.
Tak ada habis lagi kokok dia.
Kejap.
So what is the most commonest bacteria that is associated with stone formation? If you have E. coli, you have Klebsiella, you have apa lagi? Apa nama lagi? Candida can cause infection as well. So what is the commonest bacteria? I'm talking about bacteria. I'm talking about other thing. Bacteria that is associated with renal stones. Yang mana? Okay, yang mana? Yang mana tahu jawapan kan?
No.
E. coli?
E. coli is commonest bacteria, but it's not really associated with stone formation.
Proteus, doktor?
Yes, Proteus. Oh, hebat Aziz. Aziz makan rendang banyak ni, patut dia hebat. Okay, so Proteus is most common bacteria that is associated with stone formations. Okay, now back to my question. What is the most commonest comorbid in children that is associated with UTI? Okay, Zid, you know the answer. I know you know the answer. I know you. You know the answer. I know. In children, apa yang paling kata apa comorbid yang paling benign?
It's vesicoureteric reflux.
Oh, that's not benign lah. That's not benign. Okay, so there's plenty of comorbid that can cause UTI. So you're talking about VUR. Okay, VUR is a vesicular reflux. Okay, vesicular reflux. If you got this VUR, normally you will have UTI very early in your life. So less than 6 months, you will have UTIs or recurrent UTIs. So that's why it's very important to know if somebody got UTI, you want to know when actually they got UTI. If they got UTI less than 6 months old, then it's likely that the child might have congenital anomalies of the renal tract punya formation. So it could be PUJ, pelvic ureteric junction malformation. They might have congenital hydronephrosis, and they might have VUR, either grade 1 to grade 4. Okay, so these anomalies tend to cause multiple or recurrent UTI in children. Okay, especially it come very early in their life. So this child, Farah, is Farah or Fiona? I don't know which one is which basically. I think it's Fiona kot. Tak salah, Fiona atau Farah, doesn't matter. So in this child, she got the UTI when she was 4 years old. So if in 4 years old, if that is the first UTI, then you suspect this is just a acquired infection. If she got UTI, the first UTI when she was less than 6 months old, you suspect it could be congenital anomalies that lead her to have a higher risk of infection, such as VUR, PUJ, or hydronephrosis. Okay. So those are the quite severe comorbids that you can have. The benign comorbids ataupun the commonest comorbid that been associated with UTI in children is just a simple constipation. Okay, constipation. So what? So how actually constipation can lead to UTI?
I think maybe because of constipation will cause rectum to be full, so it will obstruct will macam dia obstructive kepada bladder. So when the bladder is obstructive, so there will be colonization of that bacteria in the urine because of the voiding dysfunction.
Okay,
that
so yeah, so that's correct. So basically, when you got the full rectum will block the outflow of the urine. Basically, dia tak adalah block bladder, it blocks the urethra, especially in girls. So if you got constipation in girls, the full rectum will block the urethra, the urine outflow. So most of them will have full bladder ataupun urinary retention. So if they got constipation, chronic constipation, means that they've been retaining urine multiple times in a day. So retention of urine multiple times in a day will lead to colonization of any bacteria in the bladder that can cause UTI. Okay, so those are the pathogenesis of how constipation can cause UTI, especially in girls, because girls urethra quite short compared to boys. So that's why it's more common. If you got constipation in girls, it's more common to have UTI in girls due to constipation. So when you take history for UTI, you need to take history for constipation as well. How many, how frequent the child passing stool ataupun basically passing stool lah. So is it once a day? Is it twice? Is it 2 days? Once in 2 days, and so on. And you want to know the Bristol chart for that. Is it rabbit pellet and so on? So those are the very important question about if there is any evidence to suggest the child has constipation, then the child should be on laxative, especially lactulose. Right? Try to encourage daily emptying of the rectum. Okay, so those are the question you want to ask about the child. So obviously, when you come to the antenatal history, make sure the antenatal history is normal, scan they're normal, there's no problem in terms of their kidney appearance, masa antenatal scans. You also want to know in terms of is there any sign of possible stream of urine, and is it slow stream, is it good stream, and so on. So, but the thing is, it's so difficult to know the stream of the urine because most of the time children are in the nappies, especially in the first 2-3 years of life. So sometimes assessing the stream of urine is quite difficult as well. You also want to know is there any family history of renal anomalies as well. Sometimes duplex kidneys, VUR could be hereditary as well. So sometimes family history is quite important to know in terms of renal pathology. I don't know. Nephritis is not really hereditary unless you're talking about SLE. SLE probably can be hereditary, especially in girls. Okay. Okay. Any other question you want to ask before we proceed with further question? Anything, Shaira? Anything you want to add on before we proceed further with the case?
So anyone?
What is that? Where?
Maybe can ask about the family history, like any family history with like disease, thin glomerular basement membrane disease or IgA nephropathy.
Okay, so as I mentioned before, so renal is not that many in terms of hereditary ataupun genetic issues. Cuma if there is family history of SLEs ke, duplex kidneys ke, so those are the thing that probably inherited lah. Tapi most of the time they are all acquired. Macam glomerulonephritis, post strep glomerulonephritis is all acquired. If you're talking about HSP also can be most of them are acquired condition rather than hereditary. So there's not many hereditary. Unless you're talking about something more rare lah, Alport syndrome ke, you're talking about renal tubular acidosis. So sometimes those of them can have hereditary causes. But hematuria by itself, your the way that your thought process should be infections, vasculitis, trauma, tumor. So those are kind of like, your thought process should be. Okay. All right. So I'm going to give you the physical findings, and then for the physical findings, you kind of like make a conclusion of this case. Okay. I'm going to share the screen. So this is the physical findings. So there's no pallor, so no sign of anemia. The child is apyrexia, which is no fever. So you kind of ruling out this is UTI. There's no rash, no bruising, no edema, no abdominal pain, and there's no joint pain. And the BP is 124/80, with no other physical signs. So how you made up this? How you conclude the physical finding with the history? Back to Syairah, kan? Oops.
Okay, so since this patient has no fever, so can we just rule out the? Can someone tell me what's the most possible cause points for and points against after we get the examination finding? I think we can rule out the hemosphenic purpura in this patient because of the rash, bruising, no abdominal side or joint pains.
Okay. Yeah. So what is your conclusion? Basically your conclusion, basically you just need to come with a working diagnosis and still a possible diagnosis, possible differential. So you say there is no anemia, or so no pallor. The child is not pyrexia, so you kind of like ruling out UTI. There's no rash, there's no bruising, so you kind of ruling out HSP, and then no bruising. So basically, HSP is not the thing that you are thinking about lah. However, there's one thing that you probably forgot to ask. Okay, any signs of bleeding disorders? Any question of bleeding disorders you want to ask? Like ITPs, ke, hemophilia, ke, or any rare kind of bleeding disorders you probably want to ask as well. Because sometimes if you got hemophilia, sometimes you can have hematuria. Okay, so edema, there's no edema, so you can't really ruling out nephrotic syndrome. There's no abdominal signs, means that there is no abdominal pain, there is no masses, so you can't like ruling out stone ke, ataupun you ruling out any tumors or Williams tumor, and there's no joint abnormalities. Basically, just to say that this is not really HSP. The BP 124/80, is it normal or is it high? Is it hypertensive?
Hypertensive. Hypertensive.
Hypertensive. How do you know is this hypertensive or not hypertensive? How do you know? Tengok, tanya siapa nak tanya apa lah. Tanya ni lah. Tanya Rahil. Where is Rahil? Rahil, she disappeared. Ada. Cannot hear you. You talking or not? Oh. Mic rosak.
No.
Okay, I can hear you. So how do you know this is hypertensive? This is high. Sorry. Do you agree this is high for 6 years old? Oh, okay. Yeah. You agree this is high. How do you know it's high?
Because it is more than 120 systolic, because it's less than 95% of children has this blood pressure. I'm not sure.
You're not sure. Okay. So okay. Rahil kata it's high, but she's not sure. So I'm going to pass the button to apa nama Zuzu. Zurai. Cannot hear you. Cannot hear you. Do you agree that this is hypertension? It's yes or no. You can agree or you can disagree. We are a democracy. If you don't agree, that's fine. You can say that you don't agree. You don't agree with her with reason lah. Kenapa? Takkan don't agree tapi tak ada reason kan? Kita raya-raya ni kita kena bermaaf-maafan, tak boleh gaduh-gaduh. So, is it hypertension or not? Is it hypertensive? Is it high?
It's hypertensive. But
why is the part? You don't know. Hypertensive, but you don't know.
Generally, peds have lower blood pressure normally to consider normal.
We need to know the height of her.
So, who's saying that? Siapa cakap ni? Adila apa? Nadia?
Yeah, yes.
Yes, okay. So, yes. You don't know whether this is high or not, isn't it? Because you don't have the height and weight. Because the first thing you want to know is you want to know what is the central chart for the height first. So once you know the central chart for the height, then we can plot this 124/80 to the BP central chart. Then you know whether this child has hypertensive or not, based on the 95th centile and above and so on. So the first thing is, yes, there is a number there, but it's a useless number because you don't know the weight and height. Okay, this child, even if 6 years old, this child probably weigh about 40 kilogram or 50 kilogram. So if that is the case, then the child might be on the 95th centile in terms of dia punya height dia. So you want to know the systolic of 124. It's probably high for her age anyway, but you need to be sure by plotting them on the BP centile chart first. Then you can tell whether this is high or not. It could be that it's only on the 90th centile, so that if that's the case, then it's not really hypertensive. But you know, generally, memanglah BP for child should be slightly lower than this. But you cannot say that this child has high blood pressure or normal blood pressure until you do the height centile and then plot these numbers onto the BP centile chart. Okay, so those are the things that you need to ask first. Okay, I don't know whether this is a normal BP or not, but the rule of thumb, is kalau BP systolic more than 130, diastolic more than 90, it is hypertension for children. Okay, so you know, if this child mana kali 124/80 ni, if the child got sign of kidney renal injury, then you probably need to start on medication to control the blood pressure. Okay, I'm going to stop the sharing screen there. Then I'm going to ask you further question. What investigation you would like to do in this case? Look back to Shaira. What investigation you would like to do? Tak dengar je? Tak dengar. Macam ada orang tengah naik motor. Kalau tengah potong rumput keluar.
Okay, first I would like to do urine for microscopic examination with film in this patient. And then,
okay, so you want to do urine examination or urine film? Okay, what else?
full blood count, since this patient presented with hematuria, we can
Okay, so you want to do full blood count? Okay. What else? Oh, apa lagi? So I only can hear apa Euphem dengan full blood count je. I cannot hear apa if you mention other things I cannot hear because of you've been on the boats riding on the boats there.
Anyone else want to add?
Anyone else want to add? Siapa nak add lagi?
Maybe urine diptych.
Well, she mentioned about Euphem ni. Euphem kira macam urine diptych lah. So what I can hear from Shaira is she only mentioned about full blood count and also the Euphem. I don't know whether she mentioned more than that. Maybe Amirul nak tambah
If suspected post streptococcal AGN, I would like to do ASOT, anti-septal lysine O test. Confirm.
Okay, what else?
Okay. Renal profile to look for any electrolyte imbalance.
So you want to look for electrolyte imbalance only, renal profile?
Kidney injury as well.
All right. So want to do you basically want to see urine creatinine because those are the main indicator for acute kidney injury, isn't it? Okay. Any other test you want to do? Zek? Nak buat apa ya? Nak buat I don't know, you want to do apa? Semperate ke? You want to do butter cookies ke? Almond London and so on. What do you want to do?
Doctor,
yes.
Is it possible to do the throat swab in this patient?
It's always possible. It's always possible. Yes, you can do throat swab. Okay. For what reason you want to do throat swab?
To look for any sign of infection, streptococcus.
Okay, so basically you are aiming whether there might be streptococcal colonization in the throat in this child. Okay. So what else you want to do?
Complement level such as C3.
Okay, so you want to do C3, C4 for complements. Why you want to do complement levels?
Because in post-strep AGN,
okay, post-strep
they might be low C3 level, low C3 levels.
Low C3 levels for AGN. Okay.
Urine culture and sensitivity.
Yes, definitely. You want to do urine culture and sensitivity because if it's UTI, then that can confirm the diagnosis. Anything else you want to do?
Maybe renal ultrasound to look for any structure abnormality. Okay, so you can do it. You can request renal ultrasounds for structure abnormality. Okay, fine. Anything else? So obviously your investigation should be based on your differential diagnosis as well, isn't it? So if you think this is UTI, then you can do full blood count, look for the sign of white cells, raised white cell, and also send for urine. Euphem and also urine culture to look for sign of bacteria in there. If you're talking about nephritis, then if you're talking about post-streptococcal nephritis, then you want to send throat swab with ASOT, C3, C4. You probably want to, if you're thinking about vasculitis, so what is the test that you want to send for vasculitis?
Yes.
Okay. So ESR can be a bit high in post-strep AGN can be as well because ESR is a non-specific inflammatory marker anyway. So ESR, if you got vasculitis, which is inflammation of anything, so some other inflammation of the renal parenchyma, inflammation of vessels, so you can have raised ESR. But for vasculitis, so you're talking about autoimmune conditions. So what will be the particular test that you probably want to do?
Coagulation profile.
So coagulation is mainly for the hematological disorders, Okay, so if you're talking about vasculitis or autoimmune, so what is the first line investigation you want to send?
ANA test, doktor?
Yes, okay, pandai kan. ANA test, ingatkan hantar apa semprit ni. ANA test, okay. So ANA test is or anti-nuclear antibodies. So this is the first line investigation you want to send for autoimmune condition. So if it negative, almost likely to be not to be SLE kalau ANA negative. Kalau ANA positive, then you need to do second line screening, which is anti-double strand DNAs. So if that both ANA and also anti-double strand DNA is positive, likely that the patient might have SLE. Okay. Kalau ANA negative, it's only kind of like ruling out SLE, tapi it does not ruling out other vasculitis type. So you might have orang kata apa systemic vasculitis or generalized vasculitis. You might have arthritis syndromes. So those are the rare vasculitis type of picture that has a negative ANA screening. So if you got ANA positive, then you need to do anti-double strand DNA. If it's positive, then it's likely that the patient have SLEs. Okay. The other thing, the most common thing that you want to do at this stage as well, you probably want to do LFTs as well. Okay, the reason that you want to do LFTs, you want to look for the albumin levels just to rule out nephrotic syndrome. You know this is not nephrotic syndrome because of the history and also the physical finding, but at the same time you still want to do LFTs because you want to know the albumin dia normal, then this is likely not to be nephrotic syndrome. Okay, a few years ago, 2 years ago, a student asked me a question about can you have nephrotic syndrome with a normal albumin? Apa nak jawab ni? Nadia jawab ya. Can you have nephrotic syndrome with normal albumin?
I'm not sure, doctor.
You're not sure. You cannot say like that. So what is the definition of nephrotic syndrome?
There's proteinuria. 24-hour urine of more than 300 milligram.
Okay, proteinuria. Okay.
And then there's edema. Edema.
What is the last one? Well, it should be 4, isn't it? 4 criteria for nephrotic syndrome. Edema, proteinuria. Apa lagi? Ada 2 lagi. Yang dia cuak ni, dia tengah cuak.
Hypoalbuminemia.
Yeah, hypoalbuminemia. Satu lagi? Hyperlipidemia or hypercholesterolemia. Okay. So nephrotic syndrome, at least I would say at least three lah. Mana edema, proteinuria, hypoalbuminemia. Some guideline, if you follow UK guideline, they don't really consider hypercholesterolemia ataupun hyperlipidemia. Dia cuma ambil 3 je. Edema, proteinuria and also hypoalbuminemia. So if your albumin is normal, then it does not fit the criteria of nephrotic syndrome. So you cannot have nephrotic syndrome with normal albumin unless if you have nephrotic syndrome in the remissions. If you got remissions, then your albumin will be normal. Faham? Faham ke tidak? Okay. So mana kalau patient tu datang first time, first episode of nephrotic syndrome, dia ada edema, dia ada proteinuria, tiba-tiba dia punya normal, then that's not nephrotic syndrome. It must be something else. Okay. If you see a patient that have nephrotic syndrome but already in remissions, means that they respond dengan steroid, dengan treatment and so on, then you expect dia punya edema dia dah improving, dia punya proteinuria dia improving, and the albumin also improving as well. Okay, but the child still have nephrotic syndrome. Cuma the child is in the remission. So kalau dia remission, normally they don't really have edema and they don't really have proteinuria because remission by definition is 1+ or trace of protein in the urine or no protein at all in the urine, remission. So at least 3 days in a row, trace or no protein in the urine to diagnose remissions. Okay, so kalau patient tu datang first time datang ke hospital, ada edema, ada proteinuria tapi albumin normal, then that's not nephrotic syndrome. It must be something else. Okay. Okay, then I'm going to show you the results for the patient. Okay. Okay, so this is the result of the patient. So the HB is 11.7, which is not too bad, in the normal range, but slightly on the low side. The white cell is not that high, 8.7, which is normal range. The platelets is 372. So kenapa kita nak tahu platelet dia? Why is so important to know the platelet levels?
Any bleeding disorder?
Okay, so for example, what is the most common bleeding disorder in a child or acquired bleeding disorders? Sickle cell. Sickle cell is not acquired. Sickle cell is congenital. So the most common acquired bleeding disorders in children is ITP. Okay, so idiopathic thrombocytopenic purpura. So obviously, if the child got ITP, then you expect the platelet levels will be on the low side, like as most likely less than 100 platelet. Okay, and sometimes ITP can come with just hematuria. Okay, so platelet is normal. So the sodium potassium is normal as well. It's just the urea and creatinine is on the higher side. So this patient, Farah ke Fiona ke ni, you can say that the child has acute kidney injury. The reason that you put acute kidney injury because you don't know the previous blood result for this child. So you can put this as an acute kidney injury. And then the LFT is there. So mainly you are looking at the albumin level, which is normal, 41. Okay, the urine dipsticks is 4+ of blood, protein 2+, leukocyte 1+, nitrates nil. And then microscopy, you can see the red cells and you can see the red cell cast. So, so looking at this picture, these investigations, so what will be your so you can make a conclusion on this blood test and on this investigation. So what is your conclusion? Come on, Shana. What is your conclusion? Kita kena, I think we need to be very quick sebab I think one case pun dah half 11 dah, 1.5 hours dah kita on this case. So we need to be very quick. Come on. All right. So what's your conclusion on this investigations?
This patient, I think can be post-streptococcal.
No. You don't know yet whether this is post-streptococcal.
Oh, okay.
What? So from this result, what can you make of? What can you conclude?
So for this patient, there's no bleeding disorder since platelet is normal. And then cannot say UTI because no sign of raise in white cell count.
But there's leukocyte in the urine dipstick. So is it not UTI?
Possible UTI.
Possible UTI. Okay, okay. Anything else? Or you want to pass the button to your colleague?
Anyone can help.
Anyone is not helpful. You need to pick name. If you say anyone is not helpful at all.
Shazwan.
One is that? One is that? One is that? One is that? So what can you conclude from these investigations?
So this patient may have hematuria secondary to UTI.
Okay, okay. And
because of the
okay, all of you agreed. So one is that says hematuria secondary to UTIs. All agree? Or you want to change your statement, Wani?
Can add with acute kidney injury.
Okay, acute kidney injury. Okay, okay. Wow. Okay. Is that your final? Dah kunci that statement, eh? You lock that statement. Happy?
Okay, I try like that.
You try that. Okay. So all of you agreed? Yeah, we need to vote here. So we are democracy country. We need to agree. All of you, 8 of you, need to agree. This is the case. The case you are dealing now is the hematuria secondary to UTI with acute kidney injury. All of you agree. Nampak macam apa Amirun tak not agree tu, dia berkerut muka. So, you agree or not, Amirun? Silap.
I think I'm not agree.
You don't agree, I say. Why you don't agree? Because
I'm not sure because the nitrate is near.
Nitrate is nil. Okay. Okay. So what are you thinking then?
I'm thinking of AKI secondary to acute nephritis because of the presence of proteinuria and also hematuria.
Okay. So do we now swing to support Amirun, or do we still supporting one is that?
Supporting Amirul.
Supporting Amirul. So okay, now you need to Amirul, you need to convince one is that to support you. Can you convince one is that to support you?
She already convinced.
She already convinced. So we need to hear from one is that. Do you still want to lock with your answers, or you want to swing your support to Amirun?
I think I support Amirul because the nitrates is nil. So we're just having leukocytes, blood, proteinuria, and also leukocyte positive. So it could be nephritis. So AKI, acute kidney injury secondary to nephritis.
Okay, fine. Okay. So basically, whatever you say for your diagnosis, you need to have a support evidence. So in this case, okay, the support evidence that this is, so all of you agree this is nephritis, isn't it? Okay, we know this is glomerulonephritis. We just don't know what it is, whether it's a post-strap, whether it could be as a nephritis, and so on. So because at the moment this is the result, and then you guys agreed that this is glomerulonephritis. Okay, the reason that you say this is no glomerulonephritis, according to Amirun, because of the protein and bloods in the urine. Can is it? Do you agree that is the evidence, or do you want to add on, or do you want to swing to other kind of argument? Nadia, do you agree evidence of nephritis because of bloods and the protein in the urine?
I do agree because nephritis is must have hematuria, and also the microscopy also tell there's red blood cells, so it's microscopy and macroscopy hematuria. As well, leukocyte can indicate there's glomerular injury, which cause the inflammatory at the glomerular basal membrane, and also due to the increase in urea and creatinine, spot the acute kidney injury. So I agree with the diagnosis.
So you agree with Amirul, lah? Okay, so Amirul, you got the whole support from the hall, from that one, eh? So from the hall, okay. So basically from these investigations, okay, the blood presence in the urine and also the protein levels in the urine, plus there is red cell cast in the urine, supporting there is renal involvement or renal pathology of the hematuria. Okay, if you don't see any red cell cast or red cells, tapi urine color dia memang red, then there is not renal involvement. Maknanya there's no the urine color can look red, but there is no blood in there. Okay, so that means that it is not renal pathology or not renal involvement in that particular red colored urine. Okay, because it could be any other causes for red colored urine, not just blood in the red colored urine. Okay, so in this case, you agree that there is evidence of nephritis with acute kidney injury due to the raised urea and raised creatinine. Okay, why do you say this is not UTI? Because it is leukocyte in the urine dipstick, even though there is no nitrate. What is the definition of UTI? Shaira, what is the definition of UTI?
The presence of bacteria in the urine. So it should be confirmed with urine CNS.
Okay, it should be confirmed urine CNS. Okay, so before you got urine, because urine CNS takes some time to come back. It takes about 2 to 3 days to get a urine result, urine CNS result anyway. So how do you make out from the urine dipstick that this is UTI or not UTI?
And the nitrites. In UTI, there should be nitrites from the bacterial component. The bacteria will produce nitrites in the urine.
Okay. So basically, if you do urine dipsticks, if it look positive for leukocyte and nitrates, then normally we say it is very likely that this is UTI. Okay. If you got positive leukocytes but negative nitrates, or nitrate positive leukocyte negative, mana salah satu daripada dia adalah ada positif, then you say it's possible or probable UTI. So it's not confirmed UTI. So it's not likely to UTI, but it's a probable UTI. Okay. But in this case, because if you're talking about vasculitis or nephritis, the leukocytes, the white cell is quite big to be leaked into the interstitial, into the urine. So that's why leukocyte is not as many as blood in nephritis. So that's why you see more blood, more protein, but less leukocyte, because leukocyte, if it coming from the vessels, the molecular structure of the leukocyte is quite big to pass through, to leak through the vessels. So that's why you see less leukocyte here. If the leukocyte due to infection, the leukocyte that due to infection is not coming from the blood vessels. It's coming from the superficial leukocyte due to interaction with the bacteria that cause the UTI. So that's why sometimes in the UTI you see leukocyte 3+, 4+, because the leukocyte is not coming from the vessels; it's coming from the superficial leukocyte due to the infection itself. Okay, so those are the basic investigation for this case. And then for the further testing, as you mentioned before, you want to do tooth swab for the strep infection. ASOT normally normally raised in streptococcal infection post strep AGN. Then C3 normally raised, reduced in AGN. C4 normally quite normal. You want to do ESR, ANA. If you're suspecting renal calculi, you can do abdominal X-rays, but normally it's not really helpful. It's more helpful to do renal ultrasounds to rule out any kidney anomalies or to exclude calculi. My other question is it possible if ASOTD are normal, then is it a post-strep AGN or not? If ASOTD are not raised.
I think it's possible because ASOT will decrease after 6 weeks.
Okay. But normally you develop glomerulitis within 1 to 2 weeks after the infection. So if you develop nephritis, 6 weeks after that, it's not really it's not that typical. So if the ASOT is normal, when you do the test at presentation of the hematuria, then what you want to do is you want to repeat ASOT again in 2 weeks time, because sometimes when you do it too early, the ASOT level is probably not that raised yet. So if you repeat it again after 2 weeks, then you can see the rise of the ASOT titer after that. So however, ASOT negative or ASOT normal levels in glomerulonephritis does not rule out post-strep. So you can still put down as post-strep glomerulonephritis even though the ASOT is normal. Okay. The reason for that is in this case, this is clearly mentioned that the child has cold symptoms a couple of weeks before that. So it is still possible that this is likely to be post-strep glomerulonephritis. Okay. If the child has no symptom at all before preceding the illness, then and the ASOT is normal, then you want to see what is the ANA. Kalau ANA negative, then you can put down as post-strep AGN. Okay. Kalau the throat swab dia positive for streptococcal infection, then you don't need to depend on the ASOT to put down the level of post-strep AGN. So kalau positive throat swab dia ada strep, then this is likely to be streptococcal infection that caused the glomerulonephritis. So you don't need to wait for the ASOT to put down the levels. Okay. So how are you going to treat this the child? So okay, the diagnosis in this child is most likely to be a post-strep AGN, and we know that it's typically occur 2 weeks after your symptom ataupun streptococcal infection. Sometimes it can be from the skin as well. And there is orang kata apa, theoretically kalau if you got nephritis, some children will develop oliguria ataupun reduce urine output with renal failure, but most of the time there's no changes to the urine output at all most of the time. Okay. And then as I mentioned before, the red cell cast in the microscopy of the urine indicates there is renal involvement. Okay. The thing is, you can have red colored urine, tapi there's no blood in there. Mean that it could be due to medication ke, food ke, ataupun other condition that can cause the red colored urine. That's not due to the red blood cells. Okay. Okay. So if you think that the first thing that you want to know is when you see a hematuria, you want to know where is this blood coming from? Is it from the urine or is it from the rectum? Okay. Kalau rectum, sometimes constipation can cause a bit of tear in the rectum that lead to the bleed, or sometimes it's from the vagina itself because of the period. However, if you got a 6-year-old coming with period, then you need to think about precocious puberty, or it could be abuse as well. But obviously, abuse should be more than that lah. Maknanya kalau betul-betul dia abuse, it should should be bruising around the labia majora, or it could be other signs to suggest any abuse anyway. Okay, as I mentioned before, beetroot, I don't know what is beetroot, tapi beetroot can cause red urine. Sometimes if you drink, if you ambil ubat macam cyclosporin ke, cyclophosphamide, it also can cause red urine as well. And sometimes some supplements such as vitamin B complex also can cause kind of like in orangey dark red color urine as well if you take vitamin B complex. And the condition that can cause red urine color is hemoglobinuria, but it's just the color of the urine become red. If you look into the microscope, there's no red. There's no red cells. It's just the hemoglobin that been coming from the breakdown of the red cells, then been deposited in the urine. So the urine looks red because of the hemoglobin in the urine, but there's no red cells. So hemoglobinuria is one of the things that can cause red colored urine. Okay, this is the list of possible differential diagnosis in this case. So I put down the first one, the most thing that you want to rule out is UTI. Then nephritis, it could be post-strap, it could be hand upswelling purpura, IgA nephropathy, but IgA nephropathy need to be ruled out by doing renal biopsy. Nephrotic syndrome could be as well, because 20% of nephrotic syndrome can come with hematuria presentation. Stones, trauma, hematological conditions, anatomical problems like polycystic kidney disease, tumors, medication, factitious illness, and recurrent benign hematuria. This is normally just recurrent benign hematuria. Once you do everything else, everything come back normal, then you just put down as recurrent benign hematuria. But this is just, I think, for the education and discussion boleh lah, tapi normally in the practice we don't really put down as recurrent benign hematuria anyway. Factitious illness, I don't know whether you heard about this before. Factitious illness is almost the same as Munchausen syndrome by proxy, meaning that the child, basically somebody fabricates the evidence of the illness. And then if normally, for example, macam kalau parents ada psychological problem ataupun mental issues, the parents want to seek attention from somebody else. They use their child as a proxy to attract attention from something. So in this case, let's say mak kepada Farah ataupun Fiona ni has mental illness. So what she might do is she get the urine from the child, and then she probably add on like darah daripada ayam ke ikan ke and so on. And it looks like there's blood in the urine, so they come to hospital, and then they get attention because of that. Okay, how you know this is a factitious illness or not is when you remove the child from parents' care, the child is fine, normal, nothing, no issues at all. Okay, there is no blood in the urine at all. As soon as the parents come back and look after the child, there will always be issues. Tapi budak tu normal, as mentioned, normal. There is no pain and anything. It's just that because of the evidence been fabricated by somebody, then there will always be issue with the child, even the child is well. Okay, so the treatment for glomerulonephritis, you give 10 days of antibiotics, not because you want to treat the nephritis, you want to eradicate streptococcal infection, streptococcal colonization. You cannot treat nephritis. Nephritis is basically will be resolved by itself, but it takes some time. Normally in nephritis, you restrict them to 1 liter a day or 1.5 liter a day, because some of them might have fluid overload or fluid retention. So because of that, you want to restrict the fluids. Some of them might need salt restriction diets. If they develop hypertension due to overloading of fluids, then you can give furosemide to get rid of the excessive fluids. If the hypertension not due to the overload, then you can try with a calcium channel blocker or nifedipine and amlodipine and so on. Okay. Normally, if the child looks okay, you can discharge them, and then you just follow up them through clinic. Yeah, but you ask the parents to dipstick the urine probably once a day or once a week, because sometimes PSGN takes up to 1 to 2 years to resolve. The hematuria will resolve within a couple of weeks. However, the macroscopic hematuria takes some time to resolve. So sometimes you need to monitor their renal profiles, their urine dipstick up until 1 to 2 years after the presentations, because you don't really want to leave them alone then they develop renal failure. Renal failure mainly because of the hypertension rather than anything else. Okay. Basically, I just want to mention here that UTI, post-tracheal HSP is basically the most commonest causes for the hematuria in children, and post-trap AGN is a thing that have a good prognosis in children anyway. Okay, any questions so far for this case?
Doctor?
Yes.
In children which have penicillin resistant, what do we give to them instead of penicillin?
Children has what?
Penicillin resistant to antibiotics.
Okay, resistant to antibiotics. Okay, so some children might develop bacteria that has resistance to certain antibiotics. Okay, so the resistance might develop because of the recurrent use of medication or recurrent use of antibiotics to treat any infection. So that's why it's very important that when you give antibiotics, you need to know what infection that you are fighting against. Because if you use antibiotics for viral illness, then there is a time that the child might develop resistance to the antibiotics. Okay, so it's very important that you don't give antibiotics to every single infection. Okay, so if a child develop resistance to antibiotics, you need to know what kind of bacteria that they grown. So if that bacteria resistant to that particular antibiotics, then the lab normally will test that bacteria against multiple antibiotics to see what is the sensitivity and also the resistance. So normally the child will only resistant to a couple of antibiotics, but you can use another antibiotics to fight the same infection. If you got E. coli normally sensitive to cefuroxime, augmentin, ceftazine, and so on. Sometimes you can use macrolide as well to fight E. coli. But sometimes E. coli can develop the resistance towards the augmentin and so on. So if that is the case, then you want to test for antibiotics and slightly probably second line or third line antibiotics to fight the infection. However, you can have kita panggil super bacteria macam ESBL, extended spectrum Bacillus resistant E. coli. So in that particular case, then it's so difficult to treat ESBL because most of the most antibiotics that you have available in the hospital, not going to fight that ESBL. So in that particular case, it's so difficult to treat ESBL. However, there is a regimen that we normally use. We use kind of like combination or synergist type of treatment. Even though sometimes ESBL can be resistant to tazobactam and also meropenem. So sometimes we use those combination tazobactam and also meropenem to fight ESBL. The problem is we know ESBL is multi-drug resistance. And it's so difficult to get rid. But the one that we can normally formulate to fight that ESBL is by giving synergy ataupun combination of antibiotics to fight them. Even though ESBL basically resistant to meropenem and also tazobactam. But if you have no antibiotics, then you use combination. Okay. So it's almost 12. It's 12 o'clock now. So it's only one case. You need to have another case. So you need to read quickly, eh? Because somebody nak take 5 dulu. 2 hours ni. Okay, sekejap take 5 dulu lah. Saya nak minum air sikit. Ya. Okay, who's doing the next case? Siapa buat next case? Aziz? Siapa buat next case? Ke Syarah juga buat next case? Nadia buat.
Dr. Zuzu.
Zuzu, I say. Zuzu dah tukar nama lah, jadi Zuai dia.
Hello, dengar ke?
Okay. Oh, tak dengar pula.
Hello? Everyone here?
Okay.
Yes.
Can we start with our second case?
Yep.
So for second case, Johan is a 18-month-old boy referred to the pediatric clinic because he is not yet walking. He was born at 41 weeks gestation, which is we can say that he is not a preterm baby, and uneven full pregnancy, no any postnatal complication, and generally healthy except for chickenpox 6 months ago. I think we can straight away go to developmental assessment of this boy, Johan. Can anyone comment on the gross motor assessments of this boy from the information given? Anyone?
Anyone is helpful, not helpful?
Idlan? Gross motor only.
Also, for gross motor, for this boy, he could roll over about 4 months, sat out at 10 months, crawl from 30 months, and was able to bear work on hand and feet, and put himself to standing from around 70 months. So supposedly, for this age, for 18 months, he can able to walk independently and also steadily. But for this child, he had delay in the gross motor development.
I see. Okay, thank you, Idlan. I think we can agree that he has a bit of a he has a delay in gross motor development. However, how about other assessments like fine motor, speech, and social? Can anyone
Anyone is
comment?
not helpful?
Siapa? Nadia?
For gross motor, he can scribble with either hand, and he can slot pieces into shapes of the toy. So for his fine motor, it's actually according to his age. So for his speech, he can speak single words appropriately. Supposedly at 18 months, he's supposed to can say about 6 to 10 words, and he can already show 2 parts of his body. But it's not stated here, so we need to ask more. And he can understand simple instruction. And also he can feed himself, where he can self-help skills, which is up to his age. So I think his other parts, which is fine motor, speech, language, hearing, and other, except for gross motor, is up to his age.
Okay. 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 So from this case, what are other questions you want to ask? So if you you want to complete the whole case summary kan, or dia punya long case kan. So what are the question you want to ask? Back to Zuzu.
The question I want to ask. I think we can ask more about the development of the child itself to rule out to know more about the developmental developmental assessments of the child.
Just forget about the developmental punya milestone. So you know that the child, the presenting complaint dia adalah delayed walking.
Delayed walking.
Okay, that's the presenting complaint there. So from there, how do you normally conduct your case clerking?
We can think about possible causes of the delay in the
Okay.
gross motor.
So basically, you got these conditions. So you know we'll be thinking about your differential diagnosis and you're talking about differential diagnosis, and then because of that, you need to ask further question to know what actually could be the possible causes for these conditions. Okay, so how are you going to start? Where you want to start, basically?
Where I want to start, I would like to start with.
You want to start before, before Ramadan, before Raya, or you want to start before? So you need to know where exactly you want to ask question to parents. You want to know when actually what phase of the babies that you want to ask.
Family history of any
family history tu dah jauh lah, tapi before that.
Perinatal history.
Yes. You want to know the antenatal history there. So what kind of question in antenatal history that you want to ask? What kind of question antenatally?
Antenatally, I would like to ask any problems that the mother has during pregnancy.
For example?
Such as any infection, history of infection.
What kind of infection that you are looking for?
Like a torch.
Okay. So basically, in this case, you want to know antenatal infection. So antenatal infection mainly is a torch screening that you are talking about. Torch screening is a toxoplasma, rubella, cytomegalovirus, and also herpes simplex. And those are the four viruses that you're talking about. Toxoplasmosis is mainly in the kittens, not the cat. Kitten mainly. So any of you got kittens or cats, make sure they've been vaccinated if you're planning to get pregnant. So kitten is known to carry toxoplasma. Rubella. So most of us got MMR vaccination when we were small. So rubella is quite it's very uncommon nowadays. Then you're talking about cytomegalovirus. Cytomegalovirus is so difficult to detect because most of us can get CMV infection without any symptom at all. Okay, but CMV is known to be a cause of microcephaly in babies, or sometimes it can cause calcification of the brain in babies if the mom got a CMV infection. And then herpes simplex infection, and normally antenatally if you got the herpes simplex. So those are the infection that you are talking about antenatally. What are the antenatal question that you want to ask apart from infection?
Anyone would like to answer?
Anyone is not helpful.
Rahil or Abel like to answer?
About the antenatal screening tests such as ultrasound.
Okay, so you can ask about antenatal ultrasound scan. Was the scan been told abnormal or normal? So that's one thing. Normally with the scan, they will measure the LICOR as well, kan, LICOR index. So you want to ask about the Lycor index as well. Is it normal? Is it apa? Kita tanya lah apa air tu banyak ke tak, air kurang ke tak, and so on. Okay. So those are the questions antenatally. Okay. So scan infection. Any other question you want to ask antenatally?
Is there any hypertension or gestational diabetes?
Okay, so any comorbid with the pregnancy. So normally pregnancy induced hypertension or gestational diabetes. So because those things, those two condition can actually affecting the growth of the child. Especially it also can interrupt ataupun dia boleh it can affecting the placenta function kan. So those things. So you want to know whether mom got any diabetes or hypertension during pregnancy or not. Okay. Okay. Other question you want to ask? If I go back to the Lycor, so normally kalau Lycor tu banyak, if it too much Lycor, normally there could be a problem with the swallowing of the child. Okay. If the Lycor is quite small, then it could be a problem with the kidneys. So because the kidneys produce the Lycor, and the baby will swallow the Lycor to maintain the volume. Okay, so if it too much Lycor, polyhydramnios, means that the child probably has swallowing problems or swallowing concern. If the Lycor is quite small, then it could be the kidney problem. Okay, any other question you want to ask?
Any kind of medication or drugs or alcohol that the mother might take during pregnancy?
Okay, so any medication, anything that might cause a problem to the child, especially if the mom consume alcohol, consume certain medication, especially like phenytoin, that it can cause phenytoin baby infantile phenytoin syndrome, or sometimes it can if the patient on valproate, mom on valproate also can cause valproate syndromes, alcohol, fetal alcohol syndrome, and so on. So those are the questions you want to ask. Okay. You also want to ask about what about the fetal movement during pregnancy as well. So sometimes you can have reduced fetal movement. That could be a sign of possible neuromuscular conditions, or it could be mobility or movement disorder as well. And sometimes baby can have hypermobile or two very active babies. This also could be a sign of neuromuscular or neurological condition as well. So the thing is, if this is the first child, so mom probably cannot compare to anybody to any child. So sometimes parents say probably normal. The thing is, if this is subsequent pregnancy, nombor 2 ke nombor 3, nombor 4, at least mom can compare to previous pregnancy. So that is very important. Okay, so that's antenatal histories. What else you want to ask? So if you think that you finish with antenatal history, any other history then that you want to ask?
Prenatal history.
Mm-hmm.
Maybe asphyxia or trauma during delivery.
Okay, so you're talking about trauma. What kind of trauma during delivery that you are thinking about?
During delivery, like vacuum.
Okay. So vacuum could be, but mainly any instrumental deliveries. Okay, because instrumental deliveries, either vacuum or forceps deliveries, obviously you have the superficial ataupun cosmetic the injury macam maybe facial palsy ke cephal hematoma, or something you can have a bit of laceration and so on. But that's not that significant. The most significant one is if you got instrumental delivery, it also can cause intracranial bleed as well. So those are the worries. So if the child got neurological conditions due to intracranial bleed secondary to the instrumental deliveries, then it's very important to know what kind of deliveries that the child has at birth. So instrumental delivery, need to ask those questions. So normally people ask, lahir tu lahir normal ke lahir bedah kan, lahir bedah. So orang kata lahir normal. Sebenarnya you need to know, is it normal as in normal vaginally without any instrumental, or is it because of the forceps or vacuum vacuum delivery and venous delivery. So you need to know normal, which is it normal, is it normal with instrumental. Okay. And then those are deliveries. And then what? And then after that, what question you want to ask?
Anyone? Probably postnatal.
Postnatal.
Okay, what kind of question?
Jaundice.
Okay, before jaundice, before postnatal.
Postpartum hemorrhage.
Postpartum hemorrhage is got to be mom, not really babies. Still at the deliveries.
Any admission to an ICU?
Okay, so almost there. Can you elaborate more, Amirun?
Maybe prolonged labor that leads to brain hypoxia to the baby.
Okay, so you're talking about what was the baby's condition at birth. Okay, if the patient got hypoxic ischemic injury, ataupun kita panggil hypoxic injury kan, hypoxia kan. So sometimes baby's blood supply to the brain is reduced due to the prolonged labors, ataupun maybe dia ada placenta previa and so on kan, ataupun prolonged fetal distress. So because of that, sometimes reduced blood supply to the brain will lead to babies might need prolonged resuscitation, maybe needing intubation, ventilation, and so on. So it's very important to know at birth what was the baby's condition. Does the baby need to be resuscitated? So that's why very important in this case. It says that the baby is crying immediately after at birth and did not need any resuscitation. Okay, meaning that the child, from the history, the child does not have what we call it HIE, hypoxic ischemic encephalopathy, ataupun hypoxic injury. Because if the child needs resuscitation, then most likely that the child might have hypoxic injury at deliveries, during labor. Okay, so this is very important to know this kind of problem, this kind of history. So and then barulah pergi kepada kalau dia masuk NICU, why was that? Is it because of the infection ke? Is it because of reduced feeding ke? So sometimes if the baby not been feeding quite well, then the baby might have hypoglycemia, and hypoglycemia can cause brain problem as well. Can cause HIE type of injury as well. So because your brain need glucose to work. If there's no glucose in the brain at birth, sometimes the patient might show symptom of like seizures, jitteryness, but sometimes you might miss, we call it asymptomatic hypoglycemia in newborn. Okay, so those are the dangerous one, because you don't know what is it, because the baby is not showing any sign of or any symptoms. The one that got symptoms, then you can treat, but the one who don't have any symptoms, then those are the one that difficult to recognize. Okay. So so mana kalau dia masuk NICU, for what reason? So you need to know further. You need to ask further question to parents. Okay. So that's at birth. Any other question you want to ask to parents?
Anyone, Syahira? Probably
Postnatal lah.
Postnatal.
Any postnatal, any trauma to hit?
Okay. You can mention about any past medical histories and past medical history about injuries and so on. But we're talking about postnatal. You're talking about basically mainly is neonatal jaundice lah. Okay. Neonatal jaundice perlukan phototherapy atau tak? Does it need axial transfusion and so on? So those are the questions you want to ask as well. Then after that, nothing else. Just ask about any multiple admission to hospital ke, any previous medical histories ke, and so on. So those are the thing. I want to ask you a question. Why is it important to know mechanism standing at birth? One is that. Why is it so important to know? Is there any mechanism at birth? Mechanism standing amniotic fluids at birth. Kau dah buat ONG kan masa year 3 kan? You should know this. Why is it so important to know mechanism staying at birth?
Maybe to know whether the baby has meconium aspiration.
Okay, so meconium aspiration syndrome. So why we are so afraid that baby develop meconium aspiration syndrome?
Because of asphyxia could affect the brain.
It's the same. It's the same as birth asphyxia as well. So if meconium went into your lung, okay, mana kalau meconium itu masuk dalam paru-paru kita, so it's the same that you got aspiration pneumonia. Okay, so it will so the meconium when it goes to your lung, it causes inflammation of your lung. So when it causes inflammation of your lung basically not really functioning very well. There will be reduced gas exchange between CO2 and O2. So because of that, your perfusion, your ventilation, VQ mismatch happen, and then you basically have lack of oxygen in your bloodstream. Then you got a lack of oxygen to your brain. So meconium aspiration syndrome also can cause, we call it persistent pulmonary hypertension of newborn as well. So these two conditions is so difficult to be managed sometime. And because of the complication of these two, that lead to possible hypoxic injury to the brain, might lead to the CP, cerebral palsy, in this as part of their complication. So it's very important to know the meconium aspiration. But normally, if you got a very severe meconium staining in the amniotic fluids, normally the child will need further resuscitation. But in this case, the child does not need any resuscitation at all, so which is a good thing. Okay, normally if you got severe meconium aspiration, normally the child will need intubation, will need ventilation, and also bantuan pernafasan. Why it is so important to know? Sorry, is it significant to know this chickenpox 6 months ago? So he is now 18 months. So he had chickenpox when he was 12 months. Is it significant in this case? Mana Zu? Zu mana Zu? Zu dah hilang lah. Is it significant to have this piece of information? Is it significant or not? Related to the presenting complaint, which is delayed walking. So he had chickenpox when he was 12 months old. Anyone who have not got chickenpox here? Semua ada chickenpox kan? Semua dapat chickenpox. Ke ada tak dapat chickenpox Okay, so is it significant or not? Having chickenpox at 12 months old, related to the dia punya presenting complaint dia.
I don't know, but I think having chickenpox may affect the baby's activities. That's why he can have delay in the developmental delay.
I think with chickenpox, we may concerns about is there any history of encephalitis or meningitis when he got the chickenpox that can complicate his development.
Okay, great. Okay, fine. Okay, so yep. So varicella can cause encephalitis. Varicella can cause cerebralitis. Okay. Okay. So whether it's significant or not in this case, I'm not sure. But it is important for you to think that this child might develop delayed gross motor delay due to possible varicella encephalitis or varicella cerebralitis. So varicella encephalitis, you basically has infection of your brain parenchyma. Varicella cerebralitis is an infection of the cerebellum. So if you got infection of the cerebellum, you tend to have cerebellar sign lah, macam ataxia, inability to coordinate yourself. If you got cerebritis or encephalitis, then you will be expecting more of the motor function being affected. Okay, the issue with this kid is that's fine. So we can go on later on to talk about this issue. So yeah, it could be significant to know that this child has chickenpox 6 months ago. Okay, now let's go to the developmental history. So he rolled when he was 4 months old. Is it normal or is it late or is it early?
Normal.
Normal. Okay, so 4 months old rolling, that's fine. Okay, he can set up alone at the age of 10 months. Is it late? Is it normal or is it late? So there's two stage of sitting without support, and so the first one is sitting without support with a curved back. So that one is age what? Apa please protocol cakap?
6 months with support.
So 6 months, okay? 6 months sit without support with the curved back. And then the second stage of sitting up, sitting without support is sitting up straight, sitting up with the back, with a straight back, okay? And that one is age of about 8 to 9 months old. So if he can sit alone at age of 10 months, so he's already a bit delayed, okay? And then he start to crawl at the age of 13 months. So crawling should start at what age?
8 to 9 months.
So once you start to sit up with your straight with your back straight back, you should be able to start crawling as well. So normally dia datang dengan sekali. Mana kalau dah duduk straight macam ni, lurus tegak macam ni, then normally you expect the child should be able to crawl as well. So this boy already showing signs of delay, and then he was able to bear walk on the hands and feet, pull himself up to standing at the age of around 17 months. So if you can pull yourself up, what age? Nak pull yourself up.
12 months.
Okay, so same as well, about 9 months old. So this boy is already showing signs of delayed for gross motor. Okay, so and then you look at the dia punya fine motor dia punya speech dia punya social, all looks okay kan. So looking at these developmental milestones, what is your conclusion about this developmental apa dia punya term yang korang akan pakai? What is the term that you use?
Global developmental delay.
You want to say global?
More than 2.
Is it more than 2?
No.
I think isolated developmental delay.
So it is isolated. When you say isolated, you need to say isolated gross motor delay. Okay. If you have more than one, maknanya ada dua, at least dua, then you can say global developmental delay. Okay. I want to ask you a question. So it says here he can take he is able to scribble with crayon with either hand. Kenapa this particular phrase is important? Scribble with crayon with either hand.
Meaning that the child doesn't have hand preference yet.
So when do you develop your hand preference? What age?
Age of 18 months.
18 months. Okay, so mana this child, kalau 18 months pun dia tak ada hand preference, so means that he's also might be global delay lah, kan? Betul tak? Okay. So need to go back. Siapa cakap global delay ni? Rahil ya? Rahil cakap global delay.
Yes, yes.
Okay, yeah. So Rahil is yang kata ni adalah global delay, not isolated delay. Okay. However, I want to say that the hand preference, you can leave them up to probably 2 years to develop the hand preference. Okay. Cuma ya, if you develop hand preference before the age of 18 months, then that is something that you need to think about. Need to be precautious, because if you got hand preference before the age of 18 months, then you need to think of a possible cerebral palsy. Why? Because if you got that hemiplegia, so one of the arm probably not really want to move about, so the patient will only use the free hand or the unaffected hands. So need to think about CP if the child develops a hands preference before the age of 18 months. Okay. So I wouldn't say this child is global yet, because you can allow hand preference to develop up until 2 years. So kalau by 2 years pun still don't have a hand preference, then you need to think about fine motor delay as well at that time. Okay, so basically for the speech, there are the one word sentence, understandable instruction, that's okay for speech. And then feed himself with spoon, and also feed with the teddy bear, so the social pun good as well. Okay, apart from that, mention about both parents in the early 40s. So why this is important to know the age of the parents?
Advanced maternal age have risk of having genetic problem in child.
Okay. So it is important to know the age of, basically the age of the mother, not really the father. So knowing the age of the mother is very important, because if the mother's reaching towards 40s or more than 40s, it increase the chances of trisomies baby, whether it's Down syndrome, Patau syndrome, or Edwards syndromes. Okay. Very important to know the age of the mothers, not really the fathers, more of the mothers, because mana kalau mak umur up to 40s, near 40s, more than 40s, the chances of occurrence of having trisomies baby is higher. Nowadays we've seen a lot of Down syndrome baby to mom yang umur maybe 35, 36, 37 at the moment. So we see a lot more Down syndrome babies, not even 40s, not even mom in 40s, but on the second part of the 30s, so 35 and above, also now have increased incidence of Down syndrome, of having Down syndrome babies. Okay. And then obviously parents would like to have another child, so this is very important to know, well, to give a genetic counseling about this case. So having read this slide, this case, what will be your differential diagnosis? Mana Zuzu hilang kan Zuzu.
I think we can divide it into central motor deficit, like for example cerebral palsy, or any muscle disorder, or any bone problems or joint problems.
You said you want to divide it into central nervous system, and then you want to divide into the neuromuscular, and then you say joint bone apa tu?
Bone problem.
Apa benda kita panggil? Sangkut pula dia. Sangkut pula dia. Okay lah, satu jawab lah, musculoskeletal. Hilang dia.
Maybe like hips problem.
Okay, so
Hello?
musculoskeletal, okay?
Ada.
Okay, so central nervous system, neuromuscular, and also musculoskeletal, okay? You can add on further question, for example, further category, macam apa, metabolic conditions, okay? So those are the thing that you can put down. However, for the metabolic condition, it's very important to ask question about metabolic condition. For example, any symptom of hypoglycemia at birth. You want to know question in terms of what the child has a prolonged jaundice. Sometimes prolonged jaundice also due to the metabolic condition as well. We also want to know was the child thriving or not. So failing to thrive is another symptom ataupun risk factor that been associated with metabolic condition as well. Okay, so those are questions that you can put down in this case. But okay, look, having said that, reading this case, what will be your top of the list in terms of your differential?
Top of the list probably musculoskeletal, neuromuscular or musculoskeletal, because the patient doesn't have any other problem in social or speech in other area of.
Okay, so neuromuscular, you mean what condition?
Example like Duchenne muscle dystrophy.
Okay. What about CNS?
Yes. Cerebral palsy. Cerebral palsy.
So what kind of cerebral palsy? If the child got CP, what kind of CP that the child has?
Probably spastic.
You don't know yet. You've not examined the child yet, so you don't know whether it's spastic or not. So what kind of CP that you know? Oh, dia sangkut Zuzu. Baik, bagi yang cepat sikit. Saya cepat kan. So Shaira, what kind of CP that you know?
Kind. Anyone can help?
So actually, CP we have spastic, epileptic.
You don't know the spastic or not because you've not examined the child yet. But what I'm talking about is this child got delayed walking, and so you are talking about possible lower limb problems. Problem we call it diplegia, betul tak? Okay, so diplegia or hemiplegia or quadriplegia you're talking about. So in this case, it's probably that if the child got CP, it could be that the child might have diplegia CP, isn't it? Whether it's spastic or kinetic, arthitoid, and so on, you need to examine the child first before you can put down those classification. Okay, that's fine. Okay, now I'm going to share the screen for the examination. So this is the examination of the child. So the child looks okay, looks well, interacting very well with you. Not dysmorphic. So kalau not dysmorphic, then it's probably not Down syndrome, probably not genetic. The weight there not too bad, 25th centile. Height there okay, 25th centile. The head circumference slightly big, but it's not big 50th centile. Mana compare dengan weight dengan height dia, it's not much different. Mana it's only one centile difference, not that big large difference. Kalau large difference maknanya weight and height dia 25th centile, tapi dia punya kepala dia maybe 99 centile ke 95th centile. So those are the big difference. Tapi just one centile difference is not unusual in children. And plus we know that children's head is bigger than their body normally anyway. So that's why we call it babies normally had a big head or kepala besar ataupun besar kepala. CNS, CVS, respiratory abdominal pain, abdominal examination are normal. Dia punya spine is normal, joint is normal. And there's no neurocutaneous mark, no birthmarks. Neurological examination dia, cranial nerve dia, no issues, no normal. Posture, normal tone, normal power, normal reflexes on the upper and lower limbs. Tak ada tremor. Tapi if you want to help him, if you ask him to stand, he needs help to stand. Okay, and then dia perlukan apa? Orang kata apa? Perlu pegang benda untuk dia ambil a few step while holding to both hands. Okay, so knowing the history and knowing the examination findings, what will be the top of the list at the moment? Mana Zul hilang ah?
Hello?
Ada.
From the examination, I think the top list most likely muscular disorder, because there was a normal neurological examination to suggest CP, but it seems like they have the baby have weakness of the muscles that causes him to not being able to stand properly without help.
So what do you think? You mentioned that you got CNS, neuromuscular, musculoskeletal. I add on the metabolic condition. So in the metabolic condition, what else do you expect to find if the child got metabolic condition? Metabolic condition, for example, macam apa, mucous polysaccharides, macam Hurler syndrome ke, Pompe syndrome ke, apa lagi, banyaklah MPS and MPS type 1, MPS type 2 and so on. So those are the type of muscular, the type of metabolic condition that can lead to developmental delay. So if you suspect these metabolic conditions, what findings that you expect to find? What sign you expect to find?
The dysmorphic features.
Okay, dysmorphic features. What else?
Any
the muscle wasting?
Okay. Sometimes you can have muscle wasting, but what else that is significant to find in the clinical finding that is highly suggestive of metabolic condition? Anyone? Well, sorry. Can I pick somebody? I need to pick. I'm going to pick. Apa tu? Haziq. Haziq senyap sikit. Haziq tengah makan ni. Semperik ada tu. Orang Melanda ni, Haziq.
Tak ada.
Ada. Okay. So what in particular? So if talking about metabolic condition, so for example, if talking about glycogen storage disorders kan, so glycogen dia kat mana? Saling simpan.
Liver.
So kalau simpan kat liver, so if you suspecting metabolic disorder, so what kind of findings or signs that you will find?
Abdominal distension and hepatomegaly.
Okay, so normally you're talking about you want to look for abdominal hepatosplenomegaly normally lah. Okay, so if you got a child that might be slightly dysmorphic ataupun ada orang kata soft dysmorphisms, and then when you examine the abdomen there is big spleen or big liver, then you suspect this could be metabolic conditions. Okay, so the neural exams current nerves normal, no more posture, no more tone, no more power, no more reflexes. So this, by this finding, you can say that this is not really cerebral palsy. Kan? Kalau cerebral palsy, you expect hypertonia, you expect hyperreflexia, and you expect power dia will be reduced. And plus there might be a bit of posturing, macam scissoring ke ataupun macam scissoring lah mainly. And the tremor also signify that the child might have CP as well. So sometimes CP can have tremor as well. Okay, but this child basically normal examination for neurology normal. Cuma he's not be able to stand up properly like a 18 months old child that can stand up. Okay. So now can you think can Zoo make a working diagnosis based on the history and based on the examination? What will be your top working diagnosis?
My top working diagnosis will be a neuromuscular disorder.
Neuromuscular disorder, okay.
Or musculoskeletal disorder.
Okay. Neuromuscular disorder, okay. So why do you say this is neuromuscular disorder?
Because from the finding, it seems the positive signs suggest weakness of the muscle or muscle, but no other neurological finding throughout CP.
So how do you know there's a weakness of the muscle? Because the neural exam is normal. If the power is normal, power is good power. Well, it says normal power, kan?
Weakness because the baby has to be helped to stand, and when standing he has to hold for support. So I think that's weakness, muscle weakness.
Okay.
Because the baby cannot support himself to stand.
Okay. Okay. Anyone else want to say anything different? Ke semua agree dengan conclusion ni?
I think because of the examinations are not normal, the neurological examinations are normal. I think maybe it's because of isolated gross motor development.
Okay. Okay. So mana Rahil kata this is likely to be normal leg walker, kan? Normal accelerated gross motor delay. So if you give time, probably next 6 months, 1 year, the child will walk as usual, kan? So meaning that you're going to leave the child alone until 2 years old and then see. Anyone
wait for another 6 months.
Apa?
No, wait for another 6 months.
Wait another 6 months. Anyone agree or disagree with her? Nadia agree tak? Ni housemate dekat campus, kan? Betul kan? Betul? Tak kan? Tak. So anyone agree or disagree with her? We are in the democracy country. We can disagree, we can agree or disagree. Anyone else got any other thoughts? Wanizat first ingat lah. Wanizat tengah makan kuih koci apa.
Betul. I I
you think
disagree.
you disagree? Why?
Yes,
Which
because
part you disagree?
the Rahel thought that's normal late walking because supposedly at 18 months old, the child must able to walk. But in it's like a cut off point lah. So 18 months must walk.
Is it in PITS protocol says that 18 months kena walk, kena jalan?
It's from what I read lah.
All I know, where you read from PITS protocol lah.
Daripada internet.
Internet. I thought it's Nelson. Google just now. Okay, fine. Okay. Tapi macam tadi, Zu kata neuromuscular disorder kan. Mana Zu ni? Hilang dah Zu.
Yes.
Okay. So you say this is neuromuscular disorder based on apa tadi? Because based on unable to basically need help to walk. That's it. Itu je. So that you think about neuromuscular disorder because of that particular finding.
Normal neurological examination.
Okay, yang lagi?
Also joint normal.
Joint normal. Okay. So what else in the history and also the examination that basically lead to neuromuscular disorder? Syairah?
So what is the question again?
So Zu kata tadi dia kata this is neuromuscular disorder. Kenapa dia cakap neuromuscular disorder? Because of the this finding of examination findings. Normal joint, cuma the child showing sign of lower limb weaknesses because even though the neurological examination are normal, tapi dia ada sign of lower limb weakness. Lower limb weakness. Okay. If I give you a conclusion of the examination is basically even though the child has normal examination, normal reflex, normal power, normal tone, normal posture, however, if the child is not be able, if the child needs help to stand, maknanya kalau dia duduk naik atas, kalau duduk then they want to berdiri, or if you ask them to squat but need help to stand up, then the child has, we call it proximal myopathy. Itu maksud dia yang kata yang help, he needs help to stand, holding both sides. So this is a sign of proximal myopathy. Okay, this child has proximal myopathy. Okay, agree? This child has proximal myopathy. So what is other information in the history and also in the examination findings that lead to neuromuscular disorder? So okay, kita ada proximal myopathy. Apa lagi information yang very very important? I was asking Syahira just now. Ke Syahira nak pass to your next person. Next person here I can see is Haziq. Next person next to you is Haziq. Next to Haziq is Amir, Idlan. Next to Idlan is Rahil. So you can pass the button. You want to pass to where? You want to pass to, you cannot pass back to Zu. Zu dah bagi satu jawapan dah. So what is another piece of information in the case that suggestive of neuromuscular disorder? Anyone? Abe tengah Google tu. You might see some information. Okay, semua orang macam blur. Okay, the other piece of information in this case is Johan is a boy. Okay, so if you got proximal myopathy in a boy, you'll be thinking about
X-linked.
So X-linked in this case will be
DMD.
Okay, so we're talking about Duchenne muscular dystrophy. Okay. Okay, then now I'm going to just 1 o'clock. We need to finish quick. Okay. Okay. So if you're talking about Duchenne, okay. So that will be the top priority of your list in your list. Okay. But you will have your other differential diagnosis, CP ke CP ke metabolic condition and so on. So what test you want to do, Zu? What investigation you want to pursue?
For DMD, I would like to do CK level, creatinine level. And for what's it? To confirm, probably a muscle biopsy. For dystrophin.
So basically, so you want to do CK test, CK test. If you suspect Duchenne muscular dystrophy, the CK will be high. High means that very high, maybe 10,000, 20,000, 30,000. So why the Duchenne has high CK is because that the muscles is constantly been destroyed, been break down all the time. Daily, hourly, every minute, every second, the muscles been destroyed. So that's why the CK is high. CK is part of your enzyme, part of your chemicals in your muscles, in your cells. So if you got the destruction of this muscle, of this fiber, then the CK will be high in your serum. Okay. And then to confirm that diagnosis is you do a muscle biopsy to look for the dystrophin punya ni lah. Okay. And obviously you can do genetic as well to look for the dystrophin gene. But mainly once you confirm with the muscle biopsy, then that's it. You don't need to do for the investigation. The thing that you will need genetic testing because you want to know which one of the mak atau ayah yang brought the genetics. But because it's X-linked recessive, so most likely the gene is coming from the mom. Okay, so semua salah mak lah. Okay, let's say so those are for Duchenne. If you suspect a CP, then you probably need to do CT brain or MRI brain with spines. If you think this is musculoskeletal, then you probably need to do X-rays of the joint, the hips joint, knee joint, and so on. Okay. If you suspect this is metabolic conditions, then you need to send for inborn error of metabolism screening. So you probably want to send ammonia levels, you want to send blood gases, blood glucose, and then you probably want to send a few more tests to screen for glycogen storage disorder if you suspect metabolic conditions. Okay. So I'm just going to give you. I was to share my slide regarding the differential diagnosis. Okay, can you see that? And so if you worry about global developmental delay, so if there is any sign of dysmorphic features, then it could be Down syndromes. Sometimes it could be Fragile X syndrome as well. If you talk about neuromuscular causes, it could be cerebral palsy or Duchenne muscular dystrophy. If you think about musculoskeletal causes, then you think about congenital dislocation of the hips. Okay, majority of the leg walker is a normal leg walker. So if you got about 95% of leg walker children are normal leg walker, means that if they come to you at 18 months old, okay, you do all investigation, all come back normal. Then you will tell parents that probably that this is just a normal leg walker. Hopefully the child will start walking by 2 years old, 2.5, and then the child will develop normally. But in this case, if you put normal leg walker, you need to think maknanya ni cuma adalah kategori kepada isolated gross motor delay only. Okay, if the child got other delay, then that's not normal leg walker. is something else. Okay. Okay. Failure to walk by 18 months, as Idlan says before, is a warning sign. So somebody not walking by 18 months, you need to investigate. Okay. Investigate first to find the cause. If all investigation come back negative, then barulah cakap this is just isolated gross motor delay. Hopefully it is normal leg walker. Hopefully the child will develop normally after this. Okay, and then Duchenne muscular dystrophy is the most important diagnosis to exclude, especially in boys. Kalau girls, it will be different management. So you still want to do CK. If the CK is high, then you need to think about muscular dystrophy. Cuma maybe it's not Duchenne. It could be Becker's. It could be some other proximal myopathy kind of muscular myopathy. So those are the way that your thought process should be. Okay. Sometimes the child might develop normally, walking normally up to 2 to 3 years old, and then suddenly they regress, not walking after that. So that could be another syndrome called Dravet syndrome, or sometimes it could be, we call it juvenile dermatomyositis, where you can develop inflammatory myopathy at the age of 2 to 3, especially before 18 years old. So that's a lot more to be, but this case is a delayed walking from birth. So the patient having difficulties to develop gross motor delay from birth, not that regression of skills. Okay. Okay, dah 1 o'clock. It's been 3 hours. I've not done this session 3 hours so far. It's just with you guys. 3 hours is a bit overloaded banyak ni. Kan? Kira Aziz tu kira dah kenyang dengan amal London, Aziz. Any question before we adjourn our session?
Doctor, I have a question regarding the first case scenario. So can we really differentiate? Can we really say that the hematuria come from non-glomerular or glomerular based on the color of the urine itself?
So the color of the urine, you cannot say it is non-glomerular or glomerular. What you need to do is you need to make sure that you do the microscopy. So kalau ada red cell cast, likely that this is glomerular in origin. Kalau there is no red, if you do urine dipstick, tak ada blood pun, and then when you do the microscopy, there's no red cast, then it's likely to be non-glomerular punya cause. Okay, so red cell cast is very important to ensure this red cell is coming from the glomerular. It's a renal involvement. Okay, if there is no red cell cast, means that the blood probably coming from somewhere else. It could be from the period, it could be from maybe trauma, and so on. So red cell cast is very important to differentiate between nephritis or non-nephritis or other causes. As I mentioned before, hemoglobinuria, your urine color can be red as well. Tapi you don't have the red cell in the urine when you do the microscopy. Cuma the red color from the urine is coming from the hemoglobin, because hemoglobin gives you the red color. But because hemoglobinuria is a condition where you got hemolysis of the red cell. Your red cell hemolyzed, breaking down, your hemoglobins go to being deposited in the urine, and then the hemoglobin gives the color of redness. Tapi when you do that microscopy, you cannot see the red cell. You only you cannot see the red cell. Tapi the redness of the urine color is due to the color of the hemoglobin.
Okay, thank you, Doctor.
Okay, all right. Anything else?
Doctor, is it possible the childhood obesity can lead to isolated gross development delay?
Childhood obesity, susah nak cakap lah. I wouldn't say mana obese, mana child yang dapat berisi sikit, less than 2 years old or less than 2 years old lah basically. I wouldn't say that they are obese. I think they just slightly healthy lah kan. Obese is something that you probably need to put the levels of obese if the child is more than 2 years old. lesson 2, I don't really put them as obese. I'll probably say slightly put more weight, but I think we need to work on that after the 2 years old. I don't think that childhood obesity really give developmental delay. I don't really think if the child memang saiz memang besar dari kecil kan, that shouldn't cause them to have delay in terms of their gross motor. Okay, cuma when a child is very obese, then they might have restriction of movement, but it's not a delay. Maknanya they develop the milestone already when they were small, and then they have a restriction of movement because of their size. So the milestone already developed before, and then they have restriction of movement because of their size. So I don't really think that childhood obesity really cause associated gross motor delay, because I don't think so. Okay, if you're obese, you got slightly extra weight, but your muscle should function very well. Your nerves should function very well as well. But some of us will say it's slightly late, and tapi it's not that it's overly late. Maknanya kalau if you expect a child should be walking by 18 months, and an obese child, a big size child should probably start walking by 16 months, 17 months. So still within the range of developmental milestone anyway. So I wouldn't tell that obesity is a cause of delay, unless there is other sign. For example, if you got kita panggil apa? There is one childhood obesity syndrome. I can't remember the name now. Prader-Willi syndrome. Yeah. Prader-Willi syndrome tend to have a childhood obesity. But Prader-Willi is a syndrome. So you will see more delay, not just gross motor. You see a bit more on terms of social skill dia punya delay as well, and sometimes dia punya fine motor delay as well. So it's more global delay, not just isolated delay. So I don't think childhood obesity cause isolated gross motor delay.
Okay, thank you, Doctor.
Okay. Alright, so I think it's 1 o'clock lah. Perut dah lapar dah. Yeah. So Aziz pun nak sama makan biskut air tu. So I think everyone happy eh? So if we adjourn our session, okay? Okay. Okay. So thank you very much. Thank you for joining the session. We will arrange a further session according to the timetables. If any feedbacks, you can give feedbacks to Sister Hidayah or Sister Farah. I don't know whether there will be a attendance list or not. So you can ask Sister Hidayah or Sister Farah about attendance. But obviously this session is being recorded anyway, so it should be okay. Thank you very much for coming in. Thank you very much for your participations. Thank you Syairah dengan Zu for leading the case. We will meet again. We're going to adjourn our session with Tasbih Kafarah Salawat.
Thank you very much, Doctor.
Thank you very much.
Doctor.
Thank you, Doctor.
Attendance dah isi ke semua?
Weh.
Dah. Baru je.
Belum.
Link
Isi.
Korang kalau tak ingat boleh isi lagi sekali ke?
isi je lah.
Yang 7.
Session tak asrah macam mana?
Oh,
Sekejap, record lagi. Kenapa record lagi?
stop dia. Macam mana nak stop ni? Apa record ni?
Doktor yang record lah. So doktor lah yang stop.
Doktor tak stop.
So kita kena keluar.
Cikgu, apa 3
Kita keluar lah.
Tak apa, discuss.
Okay, leave.
Okay.
Jimit.
Okay, bye.